Hello, hello, hello. I guess we'll come here. Camera, okay, the camera's not working. Okay, the camera is working. Camera is working. Okay, it's a chai. I'm going to put on a different. See, I'm on the beach now. See, the beach. Yeah, the beach.
Alberto, how are you?
Hey, Alberto, how you doing?
I'm good so far. I'm good.
Man, Italy's closed.
Italy is almost completely closed. Yes,
Wow.
trying to block this outbreak.
Yeah, wow. There's not many countries like that, right, that are closed. I don't know of too many. Spain, I think, is getting that way.
Spain is getting the same way. I think in the next days also Germany and France will do something similar. I think it's necessary, actually.
Right.
Because if we want to, you know, reduce the number of infected people and not put into too much stress our healthcare system, we must do this.
Well, this is a challenge that's never been faced in this world. This is, with the digital communication, everything is amplified for good or bad, you know, and it's hard to keep perspective on things.
Yeah, you're right. You're right. I'm a bit surprised by some countries, both in Europe, but also United States, Great Britain, who seems like they don't really understand the threat.
Really? You think so?
I think so.
Yeah.
And I'm worried they will realize the reality quite soon. I'm worried about that.
Well, yeah, there's not too many restrictions now, but you can't take any long flights. Like to Europe is closed. You can't go to Europe now from America.
I know, but you know, also in Italy, we started blocking all flights from and to China initially.
Okay.
But that was good, but not enough. It proved not to be enough. So I hope also other countries will understand that just blocking flights, it's not sufficient to contrast this outbreak.
Well, these are things that can be communicated.
Right.
Which it's amazing. I don't know, you were probably pretty young when the AIDS, when HIV was really first starting, I mean, to be known. And I couldn't imagine what it would be like if computers were around then, because it was serious. I mean, it was very serious. They knew they had a disease, but they couldn't characterize it. They couldn't get the microbe. They couldn't get the virus isolated. And they just knew, and they had no restrictions, and travel. It came from Africa originally, but then it spread out.
Right. Well, nowadays we have the means to let many people know.
Yeah.
And try to let them be more careful about that. Right.
Yeah, it would have been different when if computers were around, because that was a deadly disease. If you got it, you died. You died of it, 100%.
Absolutely.
So of course they got medications now, but at the time, a diagnosis meant death, which was serious, obviously. Of course, I'm not minimizing coronavirus, but at least it has a very low mortality.
At least, yes.
Thank goodness. So, anyways, yeah, we had a webinar on coronavirus, and we hope to have more.
It's important to spread information about this.
Yeah, for us too, because people ask us questions, and a lot of times I don't know the answers. So, but so everyone's all sad about the technique, how to share screens. Okay, just Alberto, you remember? Because I remember you did it before.
Yeah. I remember it.
Okay.
No problem for me to share screen. Well, I don't really need to share screen because I'm not a panelist, so I'm just moderator.
You're not presenting.
So
you're not presenting.
He's the president.
Well, listen, Alberto, do you want to moderate?
I think I am supposed to be one of the moderators.
Okay,
along-
so I'll just basically, well, I'm going to introduce you and then you just take over.
Okay, and I think also Aravind Kumar is the other moderator, right? But I don't see him connected.
Not
yet.
yet. He may drop in.
Okay.
So do you know the topics and all the presenters, right?
Right, yes.
Okay,
I
yeah,
have
so I'll just say, I'd like to
schedule.
turn it over to Alberto, who will moderate. And
Okay,
then you say, then you introduce It's a Chai and you know, handle the questions and then say
sure.
thank you. And then we go to the next presenter, okay?
Right, yeah. So just to make things straight, I want to double check the list of panelists, if you
Yeah.
don't mind. So
Yeah,
first
sure.
is Itichai,
Yes.
Right,
then Dr. Walid Abbas.
right.
Yeah, hi Alberto, can you hear me?
Yes,
Yes.
I can hear you. Hi.
Yeah, we have met in Japan.
I know. How are you doing?
Yeah, you and Sakam. Yeah,
Oh,
hi
man.
everyone. Wish
Miss together.
everything is okay in Italy.
In Italy, I would like to say everything is okay, but it's not actually for this
Verona is
coronavirus.
okay.
I mean, here in Verona, situation is quite okay, but there are
Okay,
some
oh.
areas in Italy where the situation is, I would say, critical. Yes.
Good morning, Juan. How you doing?
Oh, here he is.
Another moderator.
Duong is not moderating, is he?
No,
Oh,
I
here's
don't see the
Anton.
other
Oh, good. I
moderator.
never met Anton. Okay, he's coming.
Hi, everybody.
How you doing, Duong? Welcome.
Yeah, I'm fine.
Welcome from Hanoi, Vietnam.
Yes.
Good.
Hi,
I also
Alberto.
can see that Anton Konovalov joined.
Yeah, hi everyone.
Hi, Anton.
Yes.
Can you get your camera on there?
Sure.
Let me get
Just
your
a moment.
camera. Your camera's not on yet. Okay.
Good. Then I see Riccardo Stanzani with a new look.
Yeah.
Oh, okay. There's Anton. There. How you doing,
Morning,
Anton?
Professor.
John Bennett,
Yeah.
Malesh, Al
To catch
Hussein.
something.
So we are about to start, right?
Yeah, we're about to start. We're gonna, I'm gonna introduce Alberto. And
Mhm.
then Alberto's gonna basically run the hour, right?
Yeah, so
Introdu-
just let me finish double checking the panelists.
Yeah, sure, sure. Go
So Itichai, Dr. Abbas, Dr. Stanzani, Dr. Konovalov, Dr. Kumar,
Right,
right? Dr. Nagar, and Dr. Garg. Is
Right.
that correct?
right, right.
Okay, perfect.
That's it. Okay, and yeah, you might mention, you know where they all work and everything, or you don't have to mention that, just, you know?
I think I don't need to mention.
okay, oh yeah, sure, just mention that, that's fine.
Okay. So let me know when we can start. Well, we still have 2 minutes, I
Yeah.
think.
Yeah. So when people aren't speaking, please mute yourself.
Yeah.
Anton, I'm gonna mute you, okay? But when you, like, when you speak, remember, unmute. And Walid, you're unmuted now. I'm gonna mute you, Walid. Walid, excuse me. And Ricardo's already muted. Everyone's muted, okay, right. Right, Alberto's the only one unmuted. And it's a Chai, don't forget to unmute when you start to speak, okay? Yeah, okay. Okay, we got 1 minute. Yeah, let me put a more appropriate background on. This is not. I'm not on the beach, Alberto. Okay, you ready?
Sorry?
Ready to start?
Yeah. Okay.
Okay, let me hold on. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett of Neurosurgical TV. Today we're honored with the presence of a bunch of neurosurgical fellows from Dr. Cato's FUJITA Health University. I'm going to turn it over to Alberto. Okay, Alberto, welcome.
Thank you, John. It's a real pleasure to be here for our third webinar by FUJITA Health University Bantane Hospital. It's a real pleasure to meet well-known friends. And I think also today we can share some very interesting topics, both about tips and tricks in surgery, but also on technical innovations. Actually, the title of our webinar today is Advances in Neurosurgery in the Modern Era. So I think we can start with the first panelist, which is Dr. Itichai Sakarunchai from Thailand, my dear friend Itichai, who is going to talk about the basic neurovascular anatomy in endovascular therapy. So please, Itichai, you can start your speech.
Thank you. Yes, in my topic is very basic. It's not like for modern topics, but I want to share about the neurovascular anatomy once we have a chance to read on cerebral angiography. And so in outline, for 10 minutes, I will talk about the vascular anatomy, about brain and spine, and brain I divide to arterial, venous, and dentarious anastomosis. As you know, about the aortic arch, we divide from the right side to the left side of the arch from brachiocephalic trunk, left common thoracic artery, and left vertebral artery. Once you can see about the angiogram or aortogram, like in slide. So if we need to select by using the microcatheter, so we need to know about the anatomy of this vessel. So now we have many catheter shapes that we can select to the selected artery that we want to know. In this case, the left common carotid artery arising from the right side. That means this is we call the bovine arch. It's a difficult one for angiography when we perform about the selection. So the subclavian artery, they also have the many branches of the artery that we should know about the thyrocervical trunk, cordocervical trunk, or this artery is connect to the vertebral artery or internal cerebral artery that I will mention later. First step of the selection of the arch, we just start in the right side, then we just move the catheter to select the another branch, like a start from the right vertebral artery, then go to the right common carotid artery and go to the left common carotid artery and left vertebral artery. So for common carotid artery, when we see about the AP view, the cause of ICL at the first time is can cause from the laterally, then go to the medially. It's the opposite from the ECA that from go to lateral side. For the lateral view, we can see about the common for the bifurcation of the common carotid artery, it starts around the C3 and C4 of cervical spine. So when we select it, we just know about the anatomy. If we put the catheter from the lateral view of the angiography, in the front, it should be the external carotid artery. We can see many branches like an occipital artery, a facial artery, like this. And the ICA, this is behind the ECA and go to the PTAT part. But they have the two curves we should recognize. The first one, this is a PTAT part, and the second one is a cavernous part. So this is the location or the segment of the ICA that we know before. Many segments that related to anatomical and the branch that's arrived from the ICA. And this case, I want to recognize the ophthalmic artery can divide the part of intracranial artery and extracranial artery from the ICA. And from the ophthalmic artery, we can notice that the branch, the opposite side of the ophthalmic artery and slightly higher is a PCOM, then is an anterior choroidal artery. If we select it, you use the town view, and we need to smooth as seal like a Thai airways. So this is a prevent spasm or dissection. So for intracranial branches, we can see the AP view. The rentocrucide artery is arising along the A1 and M1. And the M2 and M3 is located around the limen insula and operculum. That means for the ACA, we can divide to A through AT and A4. They have many about the names that's specific to each artery. If we can remember or band, this is very good when we can interpret about the treatment planning or the complication related that brand can occur. So in this picture, you can see about the choroidal blood. That means this is for retinal artery. If they have some branch anastomosis from the outside to inside, actually when the patient have to experience to inject about the Botox, they have some events occur like a retrograde to the choroidal blood and make it the patient blind or lost about the VA. This is the most important. This case also, this is a PCOM aneurysm. That means that I mentioned before is the opposite of the ophthalmic artery. So another branch is a meningohypophyseal trunk and ILG. I will go fast because the time is very short. Our presentation, we should divide arterial phase, capillary phase, and venous phase. This is have the benefits to interpret about once we perform the balloon test occlusion. When we compare the both sides, that the occluded side, if delay about the venous phase more than 2 seconds compared the normal side, that means not enough flow. We should not sacrifice this aneurysm. The external carotid artery, they have H band, that you know before, but the most dangerous anastomosis allowed here. That can you see about this or arrow sign? This means the middle meningeal artery can anastomosis to the ICA. If once we have to embolize this band, so the embolic material can go to the ICA and it can cause stroke or retrograde to the ophthalmic artery. The patient have some problem about the visual acuity. This is the most important sign about anastomosis. So if we need to embolize some tumor around here, so very should avoid about this anastomosis to the ICA and the ophthalmic artery. For another anastomosis for the cervical that I mentioned before, it can connect to VA. Yeah, it says can have some problem once we occlude about the cervical artery. And this band, that you familiar about this band, I just pass this quickly. And we can see about the impingement mark around here. So for the posterior meningeal artery can arise from the vertebral artery, can supply the posterior dura. And they have anastomosis from SCA, agar and pygar around here. Once some branch have occluded, another branch can help to supply from the occluded side. So this picture, once we have subarachnoid hemorrhage around a P-pontine area, this is adequate for cerebral angiography. It's not adequate because we can see only about the opposite side of the right VA. We should perform the right VA to clear for the whole view of the right pygar that can represent about the subarachnoid hemorrhage. That means you know about the cause of subarachnoid hemorrhage. Yeah, it have come from many diseases. So protocol for cerebral angiography for subarachnoid hemorrhage, we should perform both common carotid artery and both VA like this. So I will script to the venous study. Venous study that we see about the superior and deep venous system that you know before. But if we want to study about the posterior vein venous system, we should perform from the vertebral arterial system. We can see the posterior fossa vein. So if we want to study about the venous, we should perform cerebral angiogram both ICA and both VA. So, and hydrocephalus, we can see from the lenticular thoramoceroid artery. Is if the angle is it's not sharp, it's more than 60 degrees, we can imply that this patient have some problem about the hydrocephalus. So for the conclusion, if we want to examine the subarachnoid hemorrhage, we should perform both common artery and both VA. For dural AV fistula, don't forget to select both ECA and both VA also because it have like a dural branch or another AVM. You know, maybe we can study for whole cerebral angiography because they have some branch to cross about the territory to supply the AVM nidus. Another I script about the spinal artery because the time is limit. So okay, this is my topic in today. Thank you.
Thank you, Dr. Itichai Sakarunchai, for this very nice presentation about vascular anatomy. Is there any question from the other participants?
Hello, this is Dr. Aravind from India.
Yes.
Dr. Itichai, like good that for subarachnoid hemorrhages, we had a very good explanation from you that which vessels should be included in the angiogram.
Yeah.
Suppose we have a subarachnoid hemorrhage on only one side of the sylvian fissure. Still, would you want to do an angio of all vessels?
If we suspected the aneurysm in that side, okay, we can perform just only one side. But if we don't know, like a diffuse subarachnoid hemorrhage, but we could not see from the CTA previously, so you should exclude another disease, especially dural AV fistula or AVM that can cause subarachnoid hemorrhage at the same. But if you perform both ICA, if you suspect in the right side, you should perform in the left side also because it's a planning for treatment. Once you have occluded some branch from the left side, you can see about the anastomosis from the contralateral side. You can predict about the outcome once you have some complication during treatment by endovascular treatment, especially form ACOM or form PCOM. Yes.
Yes, thank you.
Thank you. My pleasure.
Okay. Thank you. I see Dr. Tien has a question.
I have question for Dr.
Yes.
Ichian, yes.
Yeah.
Do you only perform the GSA to femoral or radial approach? Thank you.
Femoral approach. I always
Femoral
use the
approach.
femoral approach.
Okay.
It's really
thank you.
easy. Yeah.
Okay, thank you. I think we should go on. Welcome to Dr. Arvind Kumar for joining, my co-chair. Okay, so do you want to introduce the next speaker? Unmute your microphone.
So next we have Dr. Walid Abbas from Egypt, and he'll be talking us on the tips and tricks on ruptured ACOM aneurysms. Dr. Walid, you're online.
Dr.
Yeah,
Walid?
can you hear me?
Yes.
Yes, Dr.
Can
Walid,
you
you
see
can
me
go
now?
ahead. Yeah, you can go ahead.
Yeah. I am assistant professor of
Just be patient. The Wi-Fi is a little slow.
University, Egypt. I'm going to speak about different tricks in during the surgery in the rupture of the ACOM. I will start by a small video like the top of the rupture.
Sorry about the technical difficulties. No, this is essentially a problem of the bandwidth in Egypt where Walid is at. Walid, can you hear me okay? Walid? What we can do, Alberto, is go on to the next talk and maybe Walid can go later.
Yeah, sure. We can
Okay.
move on with the next speaker. Hopefully, Dr. Walid can have a better connection later.
Okay.
So next speaker is Dr. Riccardo Stanzani from Italy. His topic is correlation between CFD and intraoperative findings in unruptured MCA bifurcation aneurysms. So please, Riccardo, you can start your topic.
Yes, thank you. I'm trying to share my screen. Okay, can you see?
Yes, it's good.
Okay. Thank you, everybody. Good morning, and thank you for joining this meeting. My name is Riccardo Stanzani, and I'm a fifth-year resident in neurosurgery from Italy, and a previous Professor Cato Fellow, whom I thank for the kind invitation. Today, as Alberto told to us, I want to talk with you about the correlation between computational fluid dynamics, CFD, and intraoperative findings in unruptured MCA bifurcation aneurysm. With CFD software, after building a computational volumetric mesh from CT angio images, we can run algorithms that use the Navier-Stokes equation to simulate blood flow on the computational mesh. In this way, we can obtain different parameters: the pressure at the aneurysm wall, the pressure variation at the aneurysm wall, the wall shear stress, the OS index, and the vector diversification. On PubMed, we can find a lot of papers about CFD and intracranial aneurysms, most of them trying to correlate the CFD parameters and the aneurysm risk of rupture. But as we well know, aneurysm risk of rupture may also be influenced by other factors, like, for example, genetics and personal risk factors. So the role of CFD to define the aneurysm risk of rupture is still not clear at all. At the same time, some authors investigate the potential ability of CFD to provide information about the structural characteristic of the aneurysm, and that can be a very valuable tool during the treatment of aneurysm, both surgical and endovascular treatment. We all know that intraoperatively we can find the three kinds of wall: thin red wall, like this one, a normal wall, and a thick atherosclerotic wall. So what we think? We think that a thin red wall is related with medium high pressure and pressure variation, a diversification of vector, an higher OS index, and a lower WSS. In a normal wall, we can find a medium or medium low pressure and pressure variation, parallel vector, lower OS index, and medium high WSS. In a thick atherosclerotic wall, we can find a medium low pressure, convergent vector like this, higher OS index, and a medium WSS. To verify our hypothesis, we analyzed a ruptured MCA bifurcation aneurysm treated from January 2019 to December 2019 at neurosurgical department of FUJITA Health University, Bantane Hospital in Nagoya, Japan. We reviewed the intraoperative video and checked the CFD analysis and parameters of 21 patients with 21 aneurysms. We identified 30 areas of interest. 14 are thin red wall, 12 are normal wall, and 4 are thick atherosclerotic wall. For each one, we evaluated the following CFD parameters: pressure, pressure variation, WSS, OS index, and vector diversification. I don't know why this blue one, sorry. Okay. And we can see here the average of the parameters collected for each kind of wall. We can see that thin red wall has a higher pressure and pressure variation and lower WSS. We can see also that the thick atherosclerotic wall has the higher value of medium value of OS index and a different partner of vector diversification for each group. We perform a statistical analysis and we use the t-test for the comparison of mean values for continuous data and the Fisher exact test for the comparison of categorical data. We can see that we found a higher pressure variation that significantly correlates with the red thin wall. At the same time, an high OS index significantly correlates with the red thin wall and thick atherosclerotic wall. Divergent vector significantly correlate with the red thin wall, and the convergent vector significantly correlate with thick atherosclerotic wall. So we can say that in our series, in our experience, an high pressure variation, an high OS index, and a divergent vectors significantly correlate with the intraoperative finding of a thin red wall, and a high OS index with convergent vectors correlate with thick atherosclerotic wall. Thank you for your attention.
Thank you, Riccardo, for this nice presentation. Is there any question by participants of this meeting? Otherwise, I have a question.
Yes.
Of course, CFD is very intriguing method to try to predict how an aneurysm will behave over time. And there are some contrasting results in the literature, as we know.
That's true.
And probably also inflammation of the wall of the aneurysm is part of this process. So do you have any data, any experience, or any project in trying to match CFD data with histopathological findings on aneurysm walls?
There's something that introduced a colleague, an Indian colleague, Dr. Devareddy, that was in Nagoya when I was here. And is trying to correlate the CFD parameters with the histopathological findings by obtaining a portion of the aneurysm sac when we can cut the aneurysm during the surgery. it will be a long work because we need a high number of specimens, and not always you can cut the sac at the end of the surgery, but it's something that we want to do. We are trying to do this. And at the same time, I think that the results in the literature are not the same in the different centers, because there's too much software that we can use for obtaining CFD parameters, not only one software in the world. And at the same time, maybe there's something to do to obtain better algorithms with the Navier-Stokes equation. I think these two things are something that we have to work in the future.
Probably. Yeah, that it's a very interesting technique, but probably many variables still.
Yeah.
Okay.
I agree.
So if there are no other questions, Arvind, we can go ahead.
So the next speaker will be Dr. Anton from Russia. And
next speaker will be Dr. Anton from Russia, and his topic will be microsurgical treatment for posterior circulation aneurysms in the endovascular.
Yeah, hi everyone. It's nice to be here. It's my first time in a webinar with you, not the last one, I hope. So let's start with the talk. The topic for today is the microsurgical treatment of posterior circulation aneurysm. It's a tricky thing, so I would like to introduce also my colleagues, the Yuri Pilipenko and Shalva, who's my mentors, and help me with this topic. So let's begin. As everybody knows, it's kind of 15% of all aneurysm in posterior circulation aneurysm, which we're dealing with. So we have to divide them for 3 groups, depending on the localization. So it helps us to plan the surgery, the approach, and the outcome of the surgery. So also to select the method of whether it is endovascular or microsurgical. So it's upper third, middle third, and lower third. So let's look for standard techniques of microsurgery. We use sometimes the orbitozygomatic approach for upper level. So we can reach the basilar tip aneurysm, the SCA aneurysm, sometimes the PCA, proximal origin aneurysm, and so on. So here's some examples of our work. So you can see the huge aneurysm with the fusiform shape. The 4 arteries originate from the aneurysm dome, so it's not the nice one for endovascular treatment. And it also has the SAH, so kind of the tricky case. Sorry for that. Yeah, this is the video. You can see the aneurysm clipping, and it's mandatory to preserve the perforators, which one can go on the bottom of the aneurysm. So it's kind of really tricky to preserve the perforators if you do the coiling. So sometimes the microsurgery is the treatment of the choice for such kind of aneurysm. We also use the subtemporal approach, or different combinations of chirional and subtemporal at the one time. So it's kind of the combined approach. So you can reach the upper and sometimes the middle third of the basilar trunk artery localization aneurysm. So sometimes you can use the transpetrosal approach, kind of the Cavazzi approach. Also, we use the retrosigmoid approach. It's kind of the workhorse approach for pica aneurysm, which is the distal one, not the distal pica, but the distal vertebral. And also you can reach the trunk of the basilar. Here is the kind of the transcondylar modification for the posterior lateral approaches, which can we use for the vertebral basilar junction and also for pica, and also the far lateral approach. So here's the one more example of the ventral localized basilar junction aneurysm. You can see the fenestration of the basilar region, and it's not the suitable one for endovascular. So we did it microsurgical with the far lateral approach. So you can see the dura opening, the approach for cistern and proximal vertebral. Here's the temporal clipping, and you can see the dome of the aneurysm and the clipping of the dome. So it's ruptured from the first clips, but it's still okay because we can put one more clip on the neck. So here is the second clip, and it stopped bleeding. So the outcome angiographically is here. It's a total, it's a radical treatment. So the patient did well. And also we can use the mid-suboccipital approach for vertebral arteries, aneurysm. And here is the example of distal pica aneurysm, which is kind of in cisternal segment of the pica. So you can see the fusiform aneurysm, and even we cannot perform the direct clipping of the aneurysm, we can perform the opening of the aneurysm dome, resect it, and remodel the vessel with the clipping technique. So sometimes it's useful, and we can do this. Here is the angiographical control. So you can see the patency of the artery, and everything is fine. Also, we can do some kind of distal types of vertebral fusiform aneurysm with that approach. So here's an example. You can see how it's difficult to approach the aneurysm because of the nerves. So you can be careful in this type of surgery all the time. So here is the temporal clipping of the vertebral and putting the final clip on the aneurysm. Actually, we can do the revascularization for this type of aneurysm in posterior circulation. I would not go deep in this theme, but I will show some cases. Here's the fusiform aneurysm of the pica. You can see the origin of the pica and the fusiform aneurysm. So we did the reposition of the pica. So we clip the proximal distal origin of the pica at the aneurysm and cut off the distal part and re-implant it in the distal part, in the proximal part, I'm sorry. So you can see the anastomosis in situ here. It works well, and here's the control. So the patient did well after the surgery. And also you can do the occipital, you can do the in situ type side-to-side bypass and different types of occipital artery, like microanastomosis for vertebral and pica. So here's the case of the combination of the surgeries like microsurgery and endovascular. Here's the fusiform to double type of the aneurysm here with the 12 years old patient. So you can see the mass lesion here, like the fusiform, huge giant aneurysm, and the pica is originating from the one of the aneurysm. Here is the small connection between the aneurysms. So it's kind of the fusiform, and it's not suitable for endovascular treatment at first. So you can also see the thrombosis of the biggest part, and the patient started to decline in the neurologically. So we decided to go for microsurgical clipping one of the biggest part. So you can see the vertebral, the biggest aneurysm here. So we tried to find the distal part of the connection and revascularize the pica with the septal artery here. So we can trap the biggest part of the aneurysm and be careful with the pica, so it's revascularized, and you can see the control here. So we trapped it and did the thromboectomy and decompressed the brainstem. So patient started to improve. You can see the trapping of the aneurysm, and here is the patient. And then later on, so we performed the endovascular stent placement in the second part of the treatment, like in 2 months. We implant the pipeline here, and you can see the result. Here's the pipeline. Here is the trapped aneurysm with the revascularized pica. So the patient is nice. So discussion for this topic is kind of what we should do with the acute period of ACH. So here's the nice paper, which is the new one from the Barrow trial. You can see that the long-term outcome of the clipping is kind of the better than the coiling. So it's 10 years after the Brad trial. And you can see that the clipping is 93% of radical treatment versus 22 for endovascular. And some kind of endovascular surgery limitations. So it's atherosclerosis, some perforating aneurysm origin from the aneurysm, sometimes not the relief, the pseudotumor clinical presentation in the mass effect of the aneurysm if it's giant, some kind of fusiform configuration, and multiple pathologies. Like if we have the aneurysm and we go for endovascular and dual antiplatelet therapy and the patient has a tumor, we cannot go for a tumor removal because he has the troubles with the hemostasis. So it's kind of the tricky case. So thank everyone for attention, and I'm ready for any questions, and thanks so much for opportunity to speak.
Okay, thank you, Anton, for your very nice presentation and impressive cases, actually. Any question from other people?
Yeah, I would like to have a question to Dr. Itichai if he's still available.
Itichai, yes, I think he is connected. Itichai?
Professor Itichai?
Okay, maybe he is not.
Never mind. It's okay. Yeah, so I just wanted to have his opinion because I know he does a lot of endovascular work.
Yes.
So,
can you hear me?
Okay. Yeah. Okay, Itichai, we hear you.
Yeah. Okay.
Yeah. So, Dr. Itichai,
yes.
My question to you is, like, what is the incidence of perforator compromise you would see in endovascular cases for posterior circulation aneurysms?
Do you mean about the complication or compromise for?
Yeah, complications of perforator compromise.
Oh yeah. But I will talk about the for the waters then, because this is the most modern device that we can use. It even the try is that no support about the using the folder water stent in posterior circulation. But in my experience, we have a few cases of perforator occlusion after we put about the stent along the basilar artery or vertebral artery. But I think the perforator is no have the big chance to occlude. I think the flow, some flow and can through and flow through the stent. Yeah, but we can preserve it even we use the stent. But if we use the two stents together, this is the big problems, because two stents together, it can cause the major deficits from the perforating artery occlusion from the posterior circulation. But I think it's a good outcome by endovascular treatment in this era. Yes.
Oh yeah, thank you.
Okay, so Dr. Konovalov, maybe I missed the information. what's the rate of endovascular treatment versus microsurgical treatment for posterior circulation aneurysms in your institution?
Kind of 90% for posterior circulation and for endovascular. We do like 10% for complicated cases. We go for microsurgical treatment.
Right. I want to ask all the other panelists if they have the same rate in their institutions, more or less, or if someone else is doing differently. I mean, a higher number of microsurgical treated aneurysms in posterior circulation. Maybe all have the same rates, more or less. Okay, so maybe we can go on with the next speaker, who is Dr. Senthil Kumar, who will talk about the Flow 800. Dr. Kumar?
Yes.
Okay.
I will share my presentation.
Thank you.
Sorry, some technical problem.
Okay.
Share.
New technique, new tech. Okay.
Yeah, I'm coming.
There you
Sorry
go.
for the delay.
Okay,
no problem.
Here we are.
Hello, I'm Senthil Kumar from India, currently at Bantani for fellowship here. I will talk about Flow 800 today. So Flow 800 is used in aneurysm surgery, AVM bypass, and tumor surgery. Today I will talk about only the role of AVM in Flow 800 in AVM surgery. The first article was published in 2011 regarding the use of Flow 800. This software is currently available in microscope Pentaro and Kinova 900 microscopes. Indocyanine green is most commonly used fluorescent molecule since 1959. ICG-VA became popular and it is used in cerebral vascular surgery since 2003 and in AVM resection since 2007 by integrating optical technology into optical microscope. The limitation of VA is that it provides information about the vessel anatomy in the surgical field, but not about the hemodynamics within the blood vessel. Due to the lack of this objectivity, the new software Flow 800 was introduced in 2011, which can provide a semi-quantitative data by generating color maps from the fluorescent intensity obtained from ICG-VA. Advantage of this is it provides real-time evaluation. Results are reproducible, practical, and ease of intraoperative interpretation. It helps in safe surgical resection and preservation of uninvolved angioarchitecture. In AVM surgery, it can differentiate the feeding artery from the drainer and uninvolved passage vessels. It helps to understand the flow dynamics within the AVM and guide through each step of AVM excision, and helps to ensure complete resection of the nidus. After ICG-VA, the Flow 800 software produces color-coded maps in 30 to 40 seconds. The surgeon can choose the region of interest over the vessel in different colors following the software provides intensity diagram. Interpretation: arteries will appear red, veins appear blue, and arterial vein will appear yellow or orange. This is an example of a flow intensity diagram provided by the Flow 800 software. In this intensity diagram, we can check for few parameters like delay. Delay is the time interval for 0 to 50% of the fluorescent intensity, and rise time is the time interval for 0 to 90% of maximum fluorescent intensity, and time to peak is the appearance of fluorescence till it reaches the maximum fluorescent intensity. So these parameters we have to check at every stage of the surgery, and this will help in resection of AVM and understand the flow dynamics during AVM resection. But still, this Flow 800 is not without limitations. Since it depends on direct illumination, subcortical components of AVM cannot be visualized. and so it's not good for deep thread AVM. Thank you.
Thank you, Dr. Kumar, for your presentation. Any question? So I have the feeling that Flow 800 is very useful for AVMs, as you showed.
Yeah.
But I'm not very confident it has any meaning with the aneurysm surgery. I don't know if any of you have an opinion about this. Some people claim the Flow 800 is useful also for aneurysms, but I don't know how it can be useful. I see it is very useful for AVMs, but I'm asking if any of you have any experience of Flow 800 with aneurysms.
I would like to share the same view with Dr. Felity because most of the times after clipping, if you want to assess the flow in the proximal and distal or any branching vessel, most of the times it so happens that the clip we place occludes the vessels in vision. So most of the times it so happens that we could have a better idea before clipping, but to compare it with after clipping regarding the vessels, parent and distal vessel, I do think it is a little bit difficult.
Okay, any other comment?
I have another question.
Yes.
Regarding for Flow 800 is really good about the microscope software, but I want to know how much the maximum of the ICG where we can use it in one operation, because if we perform the AVM surgery in one case, so we can apply many times of ICG, but I want to know how many times or the maximum as how much milligrams that we can use this. Can I ask Dr. Kumar?
There is no restriction like that. The only thing is till the time it takes to clear from the body. As we all know, it clears very rapidly from the body. So we can use it as many times as we want. There is no limitation.
Thank you.
Thank you.
Okay, Aravind.
Now with the next speaker, we have Dr. Milesh Garg from India. So he'll be talking to us on combined endovascular supraorbital and middle temporal gyrus approach for extensive medial temporal glioma. Dr. Milesh, hello.
Hello. Am I audible?
Yeah, you are. You can go ahead.
The screen can be seen.
Yes, we can see. You can make it bigger.
Okay.
There you go.
Okay. Good evening, everyone. I'll be presenting about a unique approach which we applied in our case when I was in Bantani Hospital for my fellowship. About a case which was a 65-year-old male who presented with seizures to us, and a patient was having no neurological deficits. The CT scan was done, which was suggestive of an extensive lesion, a hypodense area in the right temporal lobe, which was extending to suprastellar as well as infratentorial region. In the CT scan, you can see the brainstem was also rotated medially as well as posteriorly. MRI brain was done, which was suggestive of in T2 image, this was suggestive of hyperintense lesion in the right temporal lobe, which was extending to suprastellar as well as infratentorial lobe, infratentorial region. The PCOM artery and PC artery were also traversing through the tumor, and MCA was also traversing through the tumor. The T1 contrast image was suggestive of no contrast enhancement. The DTI was suggestive of the pyramidal tract pushed medially as well as superiorly. So just one second. So before we planned our approach, we decided to go ahead and find out the literature, what are the options which are available. The options which were available were transsylvian, subtemporal, subcortical, as well as endoscopic. There are various advantages and disadvantages associated with each and every approach. The transsylvian approach was mainly associated with vascular injuries, as well as subtemporal approaches have got in which we need to retract the temporal lobes, as well as they have got limited working space, and there are chances of damage to the vein of Labbé. Whereas the subcortical approach need larger craniotomies and dissection of temporalis muscle. The endoscopic advantages have got, the approaches have got advantages of minimally invasive, being better illumination and panoramic view. So we discussed these advantages as well as disadvantages with the patient and the relative. But certain tumors or certain lesions, they require multiple approaches. So we decided to go ahead and do endoscopic approach in this patient, but this tumor was so extensive that it could not be removed with a single approach. So we decided and go ahead and use endoscopic approach through the supraorbital keyhole area, as well as through the temporal area, through the middle temporal gyrus, using a view side brain access system. So this is the position of the patient, and our incision marks you could see. The incision was extending from the supraorbital notch on the right side towards laterally up to the margin of the eyebrows. The frontalis muscle, as well as corrugator supercilii and temporalis muscle, were retracted, dissected, and a small burr hole was made or at the margin of the over the keyhole area, and the craniotomy of around 3 into 1 centimeter was made. On opening the dura, the frontal lobe was retracted, and we were able to visualize the tumor in the subfrontal area as well as suprasellar area. The tumor in the subfrontal area was dissected and removed with the help of suction. Because the tumor was soft in consistency, we were able to easily remove and dissect the tumor. After removal of the tumor from the subfrontal area, we were able to visualize the right optic nerve, right ICA, and we were able to remove the tumor from the opticocarotid as well as carotico-oculomotor cisterns. And simultaneously, another set of neurosurgeon team was operating through the temporal side. A curvilinear incision was made from in front of the tragus, going superiorly and posteriorly over the temporal area. The temporalis fascia was dissected, and with the help of navigation guidance, we marked the site of our craniotomy, and a small craniotomy of around 2.5 to 3 centimeter was made under navigation guidance. The dura was opened over the middle temporal gyrus in the curvilinear fashion, and a small corticotomy of around 1.5 centimeter size was made over the middle temporal gyrus. A view side brain access system was inserted, and this is our OR setup with two set of neurosurgeons operating simultaneously. The keyhole surgeon operating over the keyhole area, and another surgeon was operating to the temporal lobe over the middle temporal gyrus using the view side brain access system. So this is through the view side brain access system. The view side, you can see it's a totally transparent instrument which is made up of carbolic stuff. You can see the temporal lobe clearly through it, and the tumor which was dissected and sucked. After removal of the tumor from the temporal lobe, we were able to visualize the tentorium. The tentorium was then coagulated, and it was cut behind the fourth cranial nerve. The tumor in the infratentorial region was again dissected and removed in bits and pieces under navigation guidance. And this is at the end of the procedure through that side. The closer part, and this is the post-op CT. The midbrain, which was being pushed medially as well as posteriorly, came back to its normal place, and the gross total resection of the tumor was done. This is our patient, which was having no neurological deficit in the post-op period. Now coming to the discussion part, why we specifically used endoscopy in this particular patient? Because endoscope has got better illumination, better visualization and panoramic view. It needs a small access corridor regardless of the tumor size, whereas in microscope we need to have a access corridor which depends upon the size of the tumor. We didn't have to use any retractor device in this, whereas in microscope retractor device is usually used. But there are various advantages of microscope over endoscope also, which we need to take into consideration depending upon the case to case. Like there is no blind area in case of microscope, whereas there is a blind area behind the instruments in case of endoscope. The orientation does not change in microscope, whereas in endoscope, we have to make sure that we have to hold the instruments properly, camera properly, so that the orientation does not change. And there is a very small space in endoscope, endoscopic view, which usually gets obstructed while we are using the instruments. So this is again a pictorial representation of the size of the craniotomy or size of our approach. There are various advantages of view side brain access system, which also I have mentioned. Like it does not adhere to the brain tissue. There are clear walls which allow visualization of the surrounding structures. Elliptical ports allow bimanual dexterity. There are bevel tips which allow refined placement during surgery. It is a tubular shaped instrument which allows even distribution of pressure into the retracted brain tissue to minimize the trauma. There is a distal opening in the introducer which allows access of CSF and blood to flow through its insertion sites. It is made up of non-conducting material, which is important when using an electrocautery during tumor resection. The distal opening at the end does not reflect light, which is very important. Like in many retractors, the distal opening reflects light, so it does not allow the surgeon to observe the tumor surface as well as vessels in that area. So there are chances of vascular injury and normal brain tissue in that case, so which is avoided in this. And these are the locations which can be assessed after supraorbital craniotomies. That was regarding the view side brain access system. So the different regions which can be seen by view side by supraorbital craniotomy, ipsilateral are orbital roof, cranial 1, 2, 3, 4, anterior and posterior clinoid processes, roof and lateral wall of cavernous sinus, basal frontal lobe, gyrus rectus, sylvian fissure, anteromedial temporal lobe. Then these vessels can also be seen. In the midline, crista galli, olfactory groove, planum sphenoidal, tuberculum cellae, lamina terminalis, anterior third ventricle, pituitary stalk, and interpedicular fossa, anterior communicating artery, distal basilar artery, and perforators can be seen very well through this. So the indications of using supraorbital keyhole are aneurysms of the anterior circulation, except that of distal anterior cerebral artery, as well as it should not be used in anterior ACOM artery, which is aneurysm which is projecting posteriorly as well as superiorly, and as well as the aneurysms which are beyond the genu. This will not be visualized, MC aneurysms. So for high position basilar bifurcation and basilar superior cerebral artery aneurysms, tumors of the anterior cranial fossa and sphenoid ridge, pathologies of the sella and suprasellar region also. So coming to the advantages of our approach per se is it lead to small operative wound. The operative duration was also very small compared to such a large tumor, which require in craniotomy, in microsurgical approach, it's usually require 5 to 6 hours. We were able to complete the operation within 3 hours. There was no intraoperative blood transfusion. There was rare occurrence of post-operative epidural hematoma, usually in this particular case, because the craniotomy is small. It leads to negligible damage of temporalis muscle, less wound-related pain, and early return to work in normal life. But there are various disadvantages which we have to take into consideration, like there is a long learning curve. It is difficult to remove hard tumors with this particular approach. There is a reduced maneuverability of the instruments because of the small space and risk of prolonged or permanent palsy of frontalis muscle if the incision extends in case to more than 1 to 3 centimeters. So we have to make sure that the incision line should be in the eyebrow or just above that. It should not go beyond. Thank you very much. Any questions?
So yes, I have a question. You mentioned about, well, congratulations for the very nice operations you showed. You mentioned about the learning curve. Actually, I am, as a person who likes neuroendoscopy, I would really like to know how long does it take to a surgeon to get the experience to remove tumors in this way. And second question is related to more hard tumors, which is actually more difficult to remove. Do you also use ultrasound aspiration, or what other tricks would you suggest to remove such kind of tumors?
Sir, I'll answer the second question first, because the ultrasound aspirator, usually if the tumor is hard or firm, ultrasound aspirator would be required. But in our case, we specifically opted for this approach because the tumor, we were suspecting it to be soft rather than firm, rather than hard in consistency. So we need not require ultrasound aspirator in our case. But if the tumor is hard, it is going to take the use of ultrasound aspirator. And regarding the first question, it takes a long learning curve. Especially, I think Dr. Vijay Parihar is also online. He'll be able to answer, because Dr. Vijay Parihar is from Jabalpur Medical College in India. So he is very well experienced, and his whole center is doing a lot of neuroendoscopy. So this was a very unique case, which was done at Bantane Hospital when I was posted over there during my fellowship. So there are experts in each and every field, as you know. So I suppose he'll be a better person to answer. Dr. Vijay, are you able to hear us?
Dr. Parihar? Vijay? Not listening?
So
okay, maybe we can ask his. Okay, he's here, I think. No.
No, he's not able to hear.
No, not here. Okay, maybe he can comment later about this.
But it does take a long learning curve, because as far as what I have seen, there are different people in different fields who are expert in their own particular field. So so it probably will take 3 to 4 years to get trained in a particular neuroendoscopy, doing keyhole as well as you said brain access system. If one is, and we need to have cases, a lot of cases to, so that is very important. Thank you so much.
I believe. Okay, thank you.
Thank you so much.
Other questions to Dr. Nilesh? Okay, if not, we can move to the next topic. Dr. Manish Garg will talk about C1, C2 recurrent meningioma. Is Dr. Garg here?
Dr. Garg at present is facing some technical difficulties. He'll be back in another 2 minutes. If you could
okay, so maybe we can move on with Walid Abbas.
Yes, let's try that again.
Okay, try again.
Can you hear me now?
Yes.
Yes.
Yeah, we have some technical problems because some weather conditions in the past couple of days here in Egypt. So we are going to speak about the tips and tricks during the rupture of ACOM aneurysm intraoperatively. First of all, we have, when dealing with ruptured ACOM aneurysm, to see first what is the time of surgery. Some surgeons prefer early surgery, some person prefer late surgery. I prefer late surgery because we have a relaxed brain. There is no vasospasm, but there is an advantage that there may be an incidence of rebleeding. About early surgery, it will be like the brain is very edematous, but we will prevent vasospasm and we will prevent rebleeding. The direction of ACOM aneurysm may be like superior, anterior, superior, inferior projection, and we will talk about each one. In dealing with anterior projection aneurysm, the most important thing is to avoid excessive retraction on the frontal lobe to avoid premature bleeding. Aneurysm, you get the ipsilateral and contralateral. Can you hear me, John? Yeah, but the most important thing is dealing with the perforator. This aneurysm is very easy in getting the vascular tree A1, A2, Hubner, bilateral Hubner, and bilateral A1 and 2. But if not dealing with the perforator, the patient will come with a severe deficit. So I always say that surgery is mainly surgery of the perforators, not with the main vascular tree. Encasing with the superior projection aneurysm, the problem is in the contralateral A2. So you can first get the ipsilateral A1, ipsilateral A2, Hubner, contralateral A1 and ACOM, but sometimes you will not see the contralateral A2 until you put a pilot clip. And I will put a video at the end of this talk to see how we can deal with this case. The inferior projection aneurysm, it is very important to know which part is the dominant side, whether the left or right A1, and you go from the dominant side. But I always prefer to go from the right A1, from the right dominant, the right side, the right terional approach from the right side. We use many different approaches, but I always go through the terional approach. But I use the interhemispheric or orbital-zygomatic approach if I'm going to deal with giant ACOM aneurysm, or if there is a possibility of doing a bypass. Studying of the preoperative images is very important to know the projection of the aneurysm, which A1 is the dominant one, and if there is any associated hydrocephalus to put VP shunt or whether external drain. The anesthesia, I always say that the anesthesia is 50% of the operation, especially in ruptured ACOM aneurysm. The brain must be relaxed, otherwise you will not be able to operate. You must talk with the anesthesiologist before the operation and always tell him that during, if premature rupture occurs and you put a temporary clip, you have to elevate the blood pressure. Which side do you go, right or left side? Many surgeons always go through the dominant side, whether it is left or right, but I always prefer to go from the right side because I'm a right-handed surgeon. The right frontal lobe is much more forgiving than the left frontal lobe. The left frontal lobe, there is the Broca's area there, and if any edema happens or anything occurs, the patient will become aphasic. So I always go through the right side. The most difficult thing in going through the right side when the aneurysm is projected inferiorly, so you will go through the hypoplastic side of the ipsilateral A1. The most difficult one is to get the contralateral A1 if premature rupture occurs. But if this occurs, we're going to see how can we deal with it. I always go, the patient is put in an extended position with still from 15 to 20 degrees. I always prepare when dealing with ruptured aneurysm. The most important thing is proximal control, is to get proximal control before rupture. As long as you get a proximal control before you get the aneurysm surgery is very easy. I always prepare by 2 suction tubes. I identify the ipsilateral and contralateral A1 first. Competent assistant is very important because he is your third hand when the premature rupture occurs. Competent anesthesiologist to elevate the blood pressure. Temporary clips are available, and always use Lila retractors. This is like an aneurysm projected superiorly and a little bit anteriorly. The dominant side is the left side. This is like, I always put the images like if I'm going right terional, if I'm going, this is the carotid, the ipsilateral A1, ipsilateral A2, here is the ACOM, and here is the contralateral A1 and contralateral A2, and I will present a video of this case. I always go through the right side. although the dominant is from the left side. The right optic, right carotid, I always use a jewelry forceps and micro scissors for dissection of the arachnoid. This case is operated in the 4th day after bleeding. The bifurcation, I get the bifurcation and the ipsilateral A1, which is the not dominant, and always get the, if it is even hypoplastic or no, always put a temporary clip on it because it will always bleed. Then I will go to the contralateral left optic to get the contralateral A1, which is the dominant one. And here it will start to appear in the field. Sorry for my fingers, it's appear in the field. Dissecting the arachnoid from the contralateral A1 here. So I getting the A1, contralateral A1. Here it is the contralateral A1. Here is the lamina terminalis. Not in every case we want to open it and readjust the Leila retractors. And here is the ACOM and the aneurysm will appear. So ipsilateral A1, ACOM, contralateral A1. And here is the cotonoid between the ipsilateral A1, ACOM, and ipsilateral A2. And while we are dissecting, we didn't see the contralateral A1 yet, the contralateral A2, sorry. Premature rupture occurred. We were preparing with a pilot permanent clip to put on the aneurysm. But we cannot, till now, we can see here like the beginning of the A2, but we are not sure if it is taken in the temporary clip or no. And then we put a permanent clip, and we thought that we already finished and we were going to visualize the vascular clip. We didn't take the whole neck yet. So we put a temporary clip. We begin with the contralateral first, contralateral A1. And always do this, and then with the contralateral, with the ipsilateral, sorry, A1. And we always put it away from the ACOM so that you have a wide field. Then you're gonna remove the permanent clip, and you can visualize the contralateral A2 will be here. Here it is. And the ipsilateral A2, and using the blades of the aneurysm, the blade of the clip to dissect between the neck of the aneurysm and the ipsilateral A2 and contralateral. Here is the contralateral A2. You can see it now. It was taken the first one.
Okay, be patient. We're having some sound issues.
Then we remove the clip. The ipsilateral, then the contralateral, we remove it in clip. And then we then we visualize the vascular tree. The ipsilateral and contralateral. With the technique, we always know the direction of the aneurysm in the operative. Proximal control, hypertension, always visualization of the vascular tree after.
So thank you, Dr. Walid Abbas, for your presentation. We kind of missed the very last seconds because of probably technical problems, but the presentation was very clear. So any question from panelists? So
everyone's quiet, Alberto.
Yeah, everyone is quiet. Yeah, but yeah. I want to ask a question to Dr. Walid. In ruptured aneurysms, I was actually discussing about this topic with a colleague of mine here. And do you prefer blunt dissection or sharp dissection? Because some people say sharp dissection is safer because you don't mobilize too much the structures around. Some people say blunt dissection is safer because you cannot see very well what you are cutting. So I would like to know your opinion about this.
My favorite instrument is the jewelry force. I always like feel at night the direction of the vessel. While I'm approaching the ecom animal, I feel the arachnoid in the direction, not in the opposite direction. So I will not against the animal. But sometimes I use micro scissors too. If I found that I pull too much, there is a risk of ruptured aneurysm, I use the micro scissors. So you have to like use both, you know. But of course, like micro dissection with the micro scissors is much safer than jewelry forceps. But if you have to use the jewelry forceps, you have to use it very gently and in the direction of the aneurysm itself.
Okay, any other comment? Okay, if not, maybe Arawind, we can move on. Thank you.
The last speaker of today's webinar, Dr. Manish Garg. He's from India and he's going to talk about C1 and C2 recurrent meningioma.
Hello, good evening, everyone. So I am presenting this small case which is operated last week at Benton Hospital. It is recurrent C1 C2 ventilator meningioma. So basically, meningiomas is the second most common intradural spinal tumors. 25% of all spinal tumors here. And with ventral attachment is very challenging pathology. Spinal meningioma has very low recurrence rates, and several approach and technical modifications have been proposed for total and safe resection of tumors. Commonly, C1, C2 meningiomas involve foramen magnum and classify within craniocervical meningiomas. So they are benign character and significantly higher MIB1 index, but a high rate of recurrence was not observed in these tumors. Approaches are very high morbidity and so not justified. There is 5% recurrence rate after tumor removal. So clinical presentations, they are untypical nerve stimulation and compression syndromes like occipital neuralgia, cervical spondylolysis, or scapulohumeral periarthritis, among others. However, some patients are not diagnosed until experience limb paralysis and bowel dysfunctions. Sensory disturbances are the most common symptoms during the course of progress, which can be characterized by numbness of limbs, girdle sensation, and unstable walking. So relevant anatomy related to the surgical approaches of the C1, C2 ventrolateral meningiomas. The mean septal diameters at the levels of atlas and axis are 23 and 20 millimeter respectively. Subaxial spine, the red diameter is only 50 millimeter. The cervical bulge of the spinal cord also begins below the axis. So all these give us the adequate space at the C1, C2 cord level. So at the aspectal and atlasal levels, the facetal pillars lie anterior to the nerve roots, exiting through the intervertebral foramina. So these are the few for the anatomy revising. That is the pedicles, superior facets, and the lamina of C2, and C1 anterior arc, superior facets, and the lateral masses with vertebral artery groups showing in the arrow. A few diagrams. Again, that is after the resection of the occipital keratomy. We can see the spinal cord and the picot region. And after the removal of the atlas and axis bone, we can see the cranial nerves 11, T1, C2 roots, and also the two vertebral arteries which are forming the basilar artery. Now the posteriorly, first diagram shows the posterior approach, which shows C1 and C2, and that second diagram is posterolateral approach, which we can see there is an atlas, and I see there is a C2 calculation and the vertebral artery, and last one is the far lateral approach, which we see from the superior facet and the inferior facet and the vertebral artery and the C2 ganglion. So basically, surgical approach is patient positioning. It may be prone, 3/4 prone, lateral park bench, sitting position. Each of the positions allows focusing the surgical approaches on the occipital condyle and the vertebral artery region. So most important in C1, C2 approach is the occipital condyle and the vertebral artery anatomy. So coming to the approaches, anterior approach and basically posterior approach. Anterior approach, that is transoral, advantage is direct access to the tumor with no cord interaction. Disadvantage is lateral extension of the tumor cannot be assessed and higher risk of infection. Posterior approach, standard posterior bilateral anatomy with or without subclavian craniotomy. Advantage are lesser risk of instability. It is one of the simplest procedure. And disadvantage, no access to extrafemoral tumor. Inadequate access to anterior and anterolateral tumor. So lateral approach, the lateral access, which is directed to the lateral of the craniocervical junction and includes from top to bottom the jugular tubercle, occipital condyle, lateral mass of the atlas, and the lateral part of the C2 body. Again, the key structure in this approach is the vertebral artery, which courses around the lateral wall. So the graphical representation of different approaches. If our tumor is interdural and posterior midline, the posterior approach can be done. If tumor is lateral or anterior, then posterolateral approach can be done. If the tumor is interdural, also extradural, then posterolateral or anterolateral approach. And if tumor is extradural only, then the again posterolateral or anterolateral approach. So this is a graphic diagram. The yellow arrow shows the lateral, far lateral approach, and the red arrow shows the lateral approach. So basically, lateral approach, we remove the occipital condyle or C1 or C2 medial facets. In far lateral approach, we also remove the sometimes denser. So coming to the posterolateral approaches, laminectomy and partial medial fasectomy. Advantage are no roots or vessels intervene in the path. Root sacrifices and ligament. Sanctioning incision on the dura all contribute to the increasing the field of view in the approach. Disadvantage, extraspinal component not adequately assessed, hence recurrence may occur. Polar tumor in immediate contact with vertebral artery on the dural, all artery may not be visible. Lateral, that is far lateral transcondylar approach. Advantage, direct visualization of anterior cranial junction. Removal of both extra and interdural component facilitated. Interface between the tumor and the anterior surface of cord is well made out. Lateral opening dura avoids force factor that may cause excessive mobilization of the cord in true anterior or anterolateral lesions. Access to extension of the tumor above the foramen is possible, and post-operative scarring mates is unsuitable for tackling recurrences. Disadvantage of lateral approach, need for sterilization is more than the 1/3 hospital condyle dealt, and bilateral tumors cannot be dealt with in the same setting. That are the lateral advantage, disadvantage. So coming to our case, which operated last week, he is a 73-year-old male, initially presented in 2007 with complaints of cervicalgia, numbness all the limbs, and weakness in all limbs, more in the lower than upper limbs. CT images and MRI shows antroventral placed lesion extending from C1 to C2 lower border, more on the left side, attached to anterior durameter, interdural extradural lesion. Patient operated in 2007 and tumor was resected through posterior approach. Post-operative, patient recovered symptoms and discharged and living his life normally. But since last 6 months, that is from around October 2019, after 13 years of first surgery, he started to had gait instability, weakness in lower limbs and upper limbs, which were more on the left side. Patient was evaluated. CT MRI done shows recurrent lesion at C1, C2, enteroventral place, intervertebral lesion with significant compression of the cord. So these are the MRI images of recurrent tumor, which we saw. Tumor is enteroventral placed, more on the left side, around C1, C2 region. So surgery is planned. The first picture shows the previous incision, and the second picture is which we have done CT, and this blue region shows the defect of the previous surgery. So surgery planned more of the bone extension, and so we have done some medial facetomy also included. So these are the picture. First picture shows the tumor, and the second picture shows after the tumor excision, and that is the final after dural closure. So these are the pre-op images of the MRI which shows the tumor, and the post-op images we can show the almost that is a complete excision of the tumor. And in the post images in the CT, there is a C1 lateral is removed, and also in the C2 bilateral anatomy plus left side medial facetomy is removed. That is a blue arrow that is showing medial facetomy facets removed. And then that image, pre-op image, which shows the blue area, that is the area of bone defect, and this post-op image which shows increase. So the post-operatively patient doing well, wheelchair ambulatory, and I recovered his gradually recovering his power. Discussion is that the factors leading to recurrence are the young age of the patient, subtotal dissection of the lesion, calcification, asteroidal attachment, and multiple lesions and anti-placement. So conclusion is that all the spinal meningiomas are rare to recover. Our case implies that patient needs to follow up, and images will be done regularly as long as a patient is active in his life. Thanks.
Okay, thank you, Dr. Garg. Any question? So how much difficult was it to get to the most enteromedial part of the tumor from a posterior approach?
Enteromedial, again, that posterior, we have to go far later or extreme far later. Approach to the enteromedial, then only we can approach the enteromedial. Why only by posterior approach we can't
there's some audio problems, Alberto, I think.
Enteromedial.
Yeah, probably there are some problems with connection.
Yeah, you might be able to text that question.
Yeah. Or do you want to try again to answer my question, Dr. Garg, because we had some problems hearing you.
Yeah. I am saying. Yeah, I am saying. We can't go the enteromedial tumors. We have to go far lateral or even extreme lateral, so we can access to the enteromedial tumors.
Okay, so a more lateral approach as possible to get. Okay, to get more enteromedial.
More enteromedial tumors.
Okay, any other question? Okay.
I want to ask.
Yeah.
Like prone position or sitting position. When in sitting position, the blood will be pulling downwards. It will not be in the field, not like in the prone position. So, what's your preference?
Pardon, I don't hear what you said.
I'm asking, what do you prefer, the prone position or the sitting position?
Do you prefer the prone position or the sitting?
In lateral approach.
For tumors like the one you showed.
3/4 prone approach. We won't do generally in sitting.
Okay, we didn't get probably the answer. Can you try again, Dr. Garg, to answer the question? Please.
Yeah, we prefer the 3 prone approach or 3/4 prone approach. We not prefer sitting position.
Okay, so you don't use usually the sitting position for this.
Usually we don't do sitting position.
Okay, do you, Dr. Walid, do you have experience about sitting position with these tumors?
Yeah, we do it in sitting position so that the field is always clear and the blood is on the inferior portion of the feet, so we can dissect the arachnoid from around the tumor and we can cut this. We do it from position, but the feed is always bloody in such a case.
Right.
Okay.
Gravity is important in this kind of surgeries. Yes.
One question to Dr. Ali. In sitting position, how about the CSF drainage interrupt? Do you anytime feel that there is too much of CSF that drains through the spine?
I didn't hear you well. Can you just make your voice loud a little bit?
Sitting position.
Could you repeat the question, please?
In cervical spinal tumor, in sitting position, what is your experience about the amount of CSF that drains out?
About CSF that what?
During intradural surgeries and intraarachnoid surgeries, do you feel that there is too much of CSF draining out in sitting position?
He means in the sitting position, CSF can flow out from the wound, you know.
Post-operatively?
No, intraoperatively, I think.
Yes.
So he's mentioning about pneumoencephalon after surgery. So during surgery in sitting position, of course, you have more CSF draining out. So
do you experience incidence of any?
We didn't have a problem in that at all, even in sitting or in prone. And the most important thing at the end of the operation is tight closure of the dura. It is one of the most important things. And I want to ask about in this tumor, what do you do when you find the tumor is attached to the dura? Do you get part of the dura or you just coagulate and like a graft suture the dura?
This question is for Dr. Garg.
Yeah,
Dr. Garg, do you usually resect the implantation, the dural implantation of these meningiomas, or just coagulate the dura?
No, we generally don't use the coagulator in the spine. If we remove the posterior, we can anterolater, we can go there and coagulate the dura enter dura.
Yeah, but I think Dr. Walid is asking if you do coagulation of the implantation of the meningioma, or if you actually resect the dura.
Posterior approach, we take the dura. Then we
complete surgery,
we use Duragen or for closure.
This is an audio nightmare.
Yeah, it's a problem with audio, but I think he said they replaced the dura, right?
No. What he tried to say was in surgeries in spine, coagulation is used to the minimum, and if at all there is an attachment to the dura anteriorly, if resection is possible, we go ahead with resection, and if necessary, we replace it with an artificial substitute like a collagen substitute or an artificial dura or something like that. But in most cases, in cervical spine, I feel a coagulation is a bit risky. So being anterior, resecting of the dura will cause any problem with the CSF leak and such. So I think we can possibly go and resect the possible extent of dura.
So Dr. Walid, do you coagulate or remove the dura in these cases?
I always dissect the tumor from the dura, and it's mainly according to the age of the patient. If the patient is young, I would like to, the attachment to the dura, I would like to remove part of it so that to prevent like as much as I can from recurrence. If the patient if he's an old age patient, I would coagulate and suture the viewer. It's mainly according to the age of the patient.
So more aggressive for younger people, you say?
For young patients, yes.
Okay, fair enough.
Okay. Okay, other questions? If there are no other questions, maybe Aravind, we can close.
Yes,
this
I think
webinar.
that if there are no more questions, I think we can bring this wonderful webinar to an end.
Yes, thank you very much. I'd like to thank everyone for participating, and thank you very much, Malesh, for all your help. I apologize for the tech. Just be patient. We'll get better with the connections and the sound. And we're always open to televise conferences or webinars. I think they're going to get more common now that Corona has put severe travel restrictions in the world. So the door is always open. And thanks everyone for participating.
Thank you very much.
Good day, Alberto. Thank you.
Thank you.
Thank you. Thank you, all of you.
Thank you, John. Thank you, everybody.
Okay, we stopped.
See
Thank
you.
you very much, everyone.